Thank you for the invitation. I'm very happy to be here with you today. And I will present some of the common spine conditions that we see in the working population. I'm going to go over some of the common pathologies that cause these problems and the surgical options that we have. I don't have any relevant disclosures. So degenerative spine disease is very common, and when it becomes symptomatic, usually it presents with axial pain. So that will be low back pain, neck pain, thoracic pain. In some cases, it also causes compression of the nerve roots, and then it presents as radiculopathy, pain shooting down the leg or shooting down the arm in the case of cervical spine. And in the levels that we have the spinal cord, so cervical and thoracic spine, it can cause also spinal cord compression symptoms, and we use the term myelopathy for these symptoms. It is a very common condition, as we all know. I don't think I need to give you numbers to convince you about that. We all encounter these patients. And for the myelopathy, I just want to say that it's a little bit difficult to really calculate the prevalence, and is a condition that very often is the diagnosis is missed or is diagnosed in a delayed fashion. So we don't really have exact prevalence numbers for myelopathy. Sometimes myelopathy can have a silent presentation with some hand dexterity issues, as we'll see later on. And that's why it is easy to miss myelopathy. So about the etiology of degenerative spine disease, age definitely plays a role. Some occupational and lifestyle factors, most commonly poor posture of the spine, and also bad technique when people are lifting things plays a role. But we now believe that genetic predisposition is, if not one of the most important factors for developing spine problems. And with the spine, once we start having some degenerative changes, that changes the biomechanics and the anatomy of the spine, and then it promotes further degeneration. So it creates like a vicious cycle. So there's a problem, then it brings more problems. And again, it's a vicious cycle. In terms of the back pain or the axial pain, the pathobiology is that usually we have the formation of osteophytes, and that compresses the small nerves in the area. We also have some ingrowth of nerve endings in the areas where we have degeneration. This can also cause pain. And in some cases, you have the development of kyphotic deformity, either in the neck or in the low back, and that creates more pain because the muscles need to work more to keep the spine straight. And in some cases, then we have instability where the bone starts slipping off out of the normal position, and that translation movement back and forth creates pain from, let's say, rubbing the bones together. And what we need to remember is the pain doesn't always correlate with the imaging findings. We might have a patient that has advanced degeneration on imaging, and the pain might be minimal. And we have another patient that has milder degenerative changes, and the pain can be severe. With the MRI, we cannot really see all the changes that happen at the microscopic level, so it's not always a good correlate with the degree of pain and the degree of symptoms that the patient might have. A term that will be coming up very often in our presentation is spinal stability. So the actual definition is for the instability is that under physiologic loads, the spine cannot maintain the normal movement, and there is an abnormal movement of the bones, and that can create a neurological deficit, and it can also create severe pain. So in this particular case, there is a little bit of translation between C3 and C4, and although it is really minimal, but that patient had severe symptoms from that minimal instability. And you can see here how, the corner of that vertebral body is not aligned with the corner of the vertebra above. So there is like a 2.7 millimeters displacement. And although it is really a small displacement, but again, that patient was very symptomatic from that. Now, in terms of the radiculopathy, the pain that will be shooting down the arm or the leg, in the case of lumbar spine, there is a nerve compression that is causing that pain, and the nerve compression might be static. So by static is usually a compression that we see on the MRI. But because the spine is moving, we need to keep in mind that that compression might be dynamic. It might be happening when the patient is bending forward or bending backwards. So the MRI doesn't show us the complete picture of the nerve compression, because the MRI is done with the patient laying flat. It's not done with the patient standing up, and is not done with the patient loading the spine or moving the spine. So we don't get all the information about whether there is a dynamic compression of the nerve roots. And this compression leads to changes, microscopic changes like ischemia, inflammation of the nerve. In chronic conditions, there is also local fibrosis and permanent changes on the nerve. And this local fibrosis is one of the reasons that when the pain has been there for a very long time, even if we do surgery, then the pain might not go away, because there are microscopic changes that they're irreversible, that have happened in the nerve. And even if we do surgery and let's say we fully decompress the nerve from anything compressing it, the pain might still be there. And in regards to the myelopathy, which again is the symptoms that come from spinal cord compression, not the nerve root, the spinal cord. It has to do with static and dynamic compression, and it can lead again to ischemia and inflammation. And in addition to that, it can activate apoptotic pathways and create neuronal death. Now, let's focus on the axial low back axial pain. The lifetime prevalence is very, very high. It's up to 85% for low back, 70% for neck pain, and is one of the most common complaints for patients to seek medical care. And up to 40% of workers report some degree of disability related to neck pain. And I'm pretty sure that the numbers for low back pain are even higher. And that comes with a significant economic burden for our society. So for the acute axial pain, many times we cannot really identify where the pain is coming from. No matter if we get MRIs, X-rays, no matter what we do, sometimes we cannot really pinpoint where the pain might be coming from. The usual cause is an injury on the muscles and the ligaments that sometimes we can see that on the MRI, sometimes we cannot. And the natural history, if it doesn't have any specific characters, is usually favorable. The mean duration is 2 to 4 weeks. And what we need to keep in mind is that the spine is constantly in movement. We cannot really immobilize effectively the spine. It's not like somebody has an injury in the elbow, can put a brace, immobilize that, and allow the area to heal. For spine, because there's constant movement every time the patient is standing up, is loading the injured area. So that's why it usually takes a longer time to recover from this type of pain, even though it's coming from the muscle and the ligaments. And in terms of the clinical management, we need to start with the history. We need to get information, as we know, about location, character, any relieving, exacerbating factors. We need to do physical examination. We need to check for red flags, and I'll tell you what these are. If there are any red flags, we usually proceed directly with imaging. If not, we can try conservative treatment. Usually, we start with medications, plus minus muscle relaxant. And if the pain persists after 2 to 4 weeks, then usually we need to reevaluate the patient. And if we have not obtained imaging, we might need to get imaging at that point. Now, about the red flags are these findings from the history and physical examination that will make us suspicious that there's something else going on. It's not just a typical muscular ligamentous injury. It might be a serious pathology hiding behind these symptoms. And the serious pathology is a tumor, infection, a significant trauma. So let's see some of these red flags. So for the tumor, if the patient has a history of cancer, or if the pain is worse at night, that should make us very suspicious that there might be a recurrence of the tumor or a new tumor in the spine. So the pain at night is very, very important, because usually at night we're not the patient is not loading the spine, so you'll expect the pain to get better. But if it gets worse, then that's a red flag. And one of the theories is that during sleep and nighttime, the levels of cortisol drop. So this, let's say, a systemic anti-inflammatory response effect of the cortisol is reduced at night, so that can allow the pain from the tumor to emerge. Now, if the patient has fever, if the patient is immunocompromised for whatever reason, or if there's a history of intravenous drug abuse, that raises the suspicion there might be an infection in the spine. And again, for any of these red flags, we might proceed directly with imaging. We might not try the conservative treatment. We might just go directly get an MRI or X-rays. Now, if there is a significant trauma, or if the patient has known osteoporosis, then there is always a suspicion for a fracture or dislocation of the spine, and we might need to get imaging. Now, if the patient has any motor deficits, if there is some weakness in the leg or in the arm, if the patient complains about bowel or bladder problems, or if the patient has any of the other symptoms of cardiac equina, and we'll explain what this might be. If the patient has significant gait or balance issues, which are signs of myelopathy, all these are findings that might make us want to get the imaging sooner rather than later. And we need to remember that there are also some other pathologies like an abdominal aneurysm that can mimic the low back pain. So if the pain has a typical feature, you might want to examine the abdomen. And if the pain does not really respond to does not have the expected natural history, then that should also raise suspicion that there might be something else going on. Now, about the cardiac equina. So this is caused by massive compression of the lumbosacral nerve roots, and cardiac equina is the anatomical term for the nerve roots in the lumbar spine. And you can see here an anatomical specimen. Here is the spinal cord, and here all the lumbar and sacral nerve roots. And cardiac equina in Latin is the tail of a horse. So, the early anatomists felt that this resembles the tail of a horse, so they came up with this term. So cardiac equina syndrome is if we have something compressing all these nerve roots, and that's usually a surgical emergency, because if we don't address it in a timely fashion, it can lead to permanent leg weakness, permanent bowel, bladder, sexual function problems. So we see here an MRI on the left is a sagittal view. The abdomen will be here. The skin of the back is here. The bones of the spine, and this is the disc. This is the disc. And here's the spinal canal where the nerves are. And you can see in this area, there is this dark lesion, which is basically a massive disc herniation. All that material was between the bones was here, but because there's a disc herniation that came out and is critically compressing all the nerve roots. So, and this is an axial view where here normally we see the nerve roots, but you see this big disc herniation that is compressing all the nerve roots. So the typical symptoms is severe back and pain in the sandal area, perineal pain. There is also unilateral, bilateral leg pain, and there is problems in the sensation in the sandal area. That's probably one of the most sensitive findings that people with cardiac equina have. So sandal anesthesia. So that's very, very important to, if the patient presents with severe acute low back pain, to ask if they have any sensation problems in their private area. If they do, that should raise an alarm and get imaging and make sure that there is no massive disc herniation compressing the nerve roots. Also, because there's compression of the sacral nerve roots that control the bladder function, this patient might have urinary frequency or retention. And in some cases that, this can be evaluated, they might have sexual function problems. So for the chronic back pain, when let's say that the patient comes to us and complains about, several months or several weeks of low back pain, then, that's not the typical acute low back pain that now we change gears, let's say. And in this case, we need to get imaging to see if there is any anatomical cause for the chronic low back pain. In our evaluation, we need to also assess for any psychosocial reasons that the patient might be complaining about that pain. Sometimes there are some factors that kind of magnify, let's say, the pain that they might be feeling. So a pain that under other circumstances might be a 5, but because they have some psychological stressors, that might be like a 7 or 8 in their minds. In some cases, there are also other incentives like workers' compensation or that might be, let's say, a disincentive for the patient to admit that they are feeling better. We need to consider whether there is a rheumatological condition, and I'll mention some of the findings that will raise a suspicion for that. And if we get imaging and there is pathology there, then we need to get the opinion of a spine specialist. And nowadays we have like the spine surgeons like myself, but we're fortunate enough to have also the interventional spine specialists who are colleagues from either anesthesia or from rehabilitation medicine, that they do injections in the spine or they do other interventions, which is, let's say, a step before surgery. And if there is no anatomical cause of the pain in imaging, or that anatomical cause is not really something worrisome, then we can consider medical management. Now, in terms of the medical management, a very important part is education. We need to make sure that their work ergonomics are good, that, for example, if they do an office job, and they have neck pain, then we need to make sure that, the screen is at the eye level, that they don't have to spend many hours with their necks in a not normal, not neutral anatomical position. If they spend hours looking down, looking to the left, to the right, they subject their spine to forces that, if it's for a short period of time, it's fine, but if it is for many hours, then our spines are not made for us to be looking down for many hours, as the modern lifestyle or some of the, jobs sometimes require. For people who do more physical jobs, it's very important to make sure that they use proper lifting technique. And what is important is to keep the normal lordosis of the lumbar spine whenever they lift something. It's very, very important not to bend their backs when they're lifting something, because again, the normal lordosis is the anatomical position that our spines can tolerate high levels of loading. If we bend our spine when we're lifting something, we subject the spine to loading in a position that is not made to tolerate these high loads. So you might have seen the Olympic Games, the weightlifters, they lift these, massive weights, but all of them, they keep their spines straight and they keep like the normal lordosis when they do that. And again, good posture is very, very important. In my mind, these are very, very important modifiable factors that can make the difference in these patients that present to our practice with this non-specific neck or low back pain, and they have some minimal degenerative changes on imaging. In some cases, we might want to refer them for physical therapy. That's very, very important, because with physical therapy, they can strengthen their muscles that keep the spine in normal alignment. And some patients say, "Oh, I'll go to the gym and do the exercises on their own," which might be fine if they have experience, but many of them don't really have that expertise to know exactly what kind of exercise they need to do. So we usually refer them to physical therapists to do some sessions under the supervision. And the goal will be to graduate, let's say, from physical therapy with the knowledge on what kind of exercise they need to do to keep their spine muscles strong. And that's a very good long-term measure to prevent spine degenerative changes. There are some now non-pharmacological treatments. Some of them have a moderate quality evidence, like, again, exercise, rehabilitation. And there's some other alternative treatments that they have a very low quality evidence about their efficacy. Now, the good thing with these treatments is that they're usually safe. So for many of them, if they want to proceed, I will not have an objection if they want to give it a try. But I'm not really convinced that they have a high level of effectiveness to make me refer them for something like that. What I definitely believe is the value of physical therapy For these other types of treatments, again, for most of them, I'm not against, but I usually don't initiate that referral, and I don't usually put the patients pay out of pocket, because some of these treatments, they need to pay out of pocket. I'm not convinced that the value is there, but if they want to give it a try, that's fine with me. Now, if the non-pharmacologic therapy is not effective, then we can proceed with pharmacological treatment. But we need to be very, very careful to avoid transitioning to stronger pain medications, especially opioids. That's something that the pharmacological treatment is something that's usually done by the interventional spine specialist. I'm not the person who prescribes this medication, so I would like to say anything more about it, because that's not my area of expertise. Now, I mentioned earlier about rheumatological causes, so that's something we definitely need to rule out, especially if we're like primary care providers. And pain at night or when the patients wake up in the morning is, let's say, a red flag for the presence of a rheumatological condition. So overnight, because they're not moving their joints, they're not moving their backs, so there is some stiffness. So when they wake up in the morning, their joints are stiff from the rheumatological condition, and then they complain about more pain when they wake up. And that as they start moving, that pain kind of subsides. So that's the opposite compared with degenerative pain, which usually gets worse during the day and as they load their spines more and more. And we suspect something like that. We might need to get x-rays to evaluate if there is any sacroiliac joint problems, or get the opinion of a rheumatologist. We need to keep an eye for drug-seeking red flags. Patients that they might come to us, they come because they're seeking pain medications, and there are some red flags about that, so we need to be careful about that. If we ever want to prescribe opioids, we need to check iStop, and we need to check some for red flags from the history. If they usually change providers, or if there's something not a little bit vague from the past records. So there are some red flags about drug-seeking behavior. Now, if they have leg pain, so we're talking about lumbar radiculopathy, we need to add in our examination the neurological exam. We need to also check we need to do a vascular exam in the legs and check that there is no problems with the arteries of the legs. And we need to check also the joints of the leg. Sometimes there might be a hip pain that mimics lumbar radiculopathy. And we need to check again for the red flags that we mentioned. In the neurological exam, we assess the strength using this grading scheme from 0 to 5. So 5 is normal full strength, 0 is no movement at all, and 3 is when there is movement just enough to overcome gravity. And 4 is movement against gravity and some resistance, but not full strength. So this is the grading scheme that we use, and you might see in the notes, 5 out of 5 in all extremities or something like that. There is also sensory grading that we don't really use it as often. We might just say decreased sensation in that distribution. Now, when we want to evaluate the L2 nerve root, we usually assess the hip flexion, and we assess if there is any weakness there. And the L2 radiculopathy usually causes pain in the upper anterior thigh. For L3, we check the knee extension, and the pain is anterior thigh, but going down to the knee. For L4, nerve root is more like a pain below the knee, and we check the dorsiflexion of the foot. L5, we check the toe extension, and it's pain that shoots down to the dorsum of the foot, and usually patients complain that the pain goes all the way down to the top, to the big toe. And for S1, we check the plantar flexion of the foot, and the pain shoots down to the foot, and usually they complain that goes to the side or under the foot. We also check for some abnormal reflexes. So these are signs that there might be spinal cord compression. So when we have these abnormal signs like the Hoffman sign or clones in the foot or the Babinski sign, then this might mean that there is spinal cord compression either at the cervical or the thoracic level for cervical for Hoffman sign, and cervicothoracic for both Klom's and Babinski. And that might make us want to get an MRI of the cervical or the thoracic spine to make sure that there's no spinal cord compression at these levels. Now, for the radiculopathy, and we see here a view of lumbar spine. This is an axial view, so the belly will be over here, the skin of the back will be down here, and we're looking from the feet towards the head. So that will be the right side, that will be the left side. And the white area here is the cerebrospinal fluid, and the dots are the nerves inside the thecal sac. And you can see, I mean, this is the nerve on the right side. And you can see on the left side that there is this dark area. So this is a disc herniation that is compressing the nerves in that spot over here, because this is bone, this is the disc herniation, and here we have a nerve root that is under pressure. Look here, the normal nerve root, how it looks, and there's probably a compression of nerve there. So in that case, if there is any weakness, if there are any bowel or bladder issues, which raise the suspicion for cardiac guina, as we said, or if the pain is refractory and hasn't responded to non-operative treatment, then we get MRI, and we might need to get a consultation with surgery, with spine surgery. If we only have some pain that is not very severe, we can try the non-operative treatment with NSAIDs. We can consider a Medrol dose pack, and then if the symptoms persist, then we need to get an MRI, or if we have an MRI and so let's say a finding like that, and the symptoms persist, then we can consider either an epidural steroid injection or surgical consultation. About the lumbar disc herniation, so this is a view of the lumbar spine. Here is the pelvis. And here they cut the spine. So here's the thecal sac, here is the pedicle, and here's the disc herniation. And I like a lot this image because it shows that a disc herniation at L4, L5, if it is a little more to the side, it might compress the L4 nerve root. If it is a little bit towards the midline, it might compress the L5 nerve root that exits through the lower level. So when the surgeons or the interventional spine specialists, we evaluate the MRI, we try to correlate where the pain is, and if the disc herniation that we see on the MRI correlates with the distribution of the pain. Now, about the disc herniations, we usually use these three zones, let's say, to describe where the disc herniation is. These are axial views of the lumbar spine, and these are sagittal views. The belly is here, skin of the back. On the axial view, the belly is this way, the skin of the back is this way. And you can see here there is a big disc herniation, and we can see here that same disc herniation, and it is in the central zone. And when we do surgery for that, we usually do a laminectomy, and we will see what that is. And when it is in this foraminal or far lateral zone, we might, when we do surgery, we might need to approach it through a different approach. So when do we usually consider doing surgery for these lumbar disc herniations? So first of all, we need to make sure that the disc herniation that we see on the MRI explains the patient's symptoms, because it might be an incidental finding. The pain might be coming from a totally different pathology. So we don't want to do an unnecessary surgery. Usually we try several weeks of non-operative treatment, but if the pain is severe and the patient cannot walk, cannot get out of bed, or if the patient is working and cannot really they cannot do their job because of the pain, or if there's any significant motor weakness, then we might skip the non-operative treatment and go directly with surgery. Now, you will hear very frequently the terms laminectomy and laminotomy, and that has to do with the amount of bone that we remove when we try to approach the nerve. So this is a dorsal view of the lumbar spine, and the purple dots show the bone that we remove when we do a laminectomy. While when we're doing a laminotomy is a more focal, let's say, removal of the bone. So when we do surgery, our goal is to decompress the nerve roots by removing the disc herniation. And when we remove the disc herniation, we also check the disc space to see if there are any other loose fragments. If they are, then we need to remove them because otherwise they will come out very soon and the patient will have a recurrent disc herniation, will have to undergo treatment again. And we need to be very careful not to remove too much bone. If we remove too much bone when we do that operation, we can create iatrogenic instability. There are some rules that we follow, but the general principle is that we need to preserve that side of the lamina here. If we remove too much bone and we get very close to that yellow line, then this bone might crack there, and the patient might have severe low back pain from this fracture. Let me go back to that. So for this herniation here, usually what we do is we do a midline incision. We go inside, we make an opening in the bone, usually in the form of a laminotomy, which is the green area here. And then we retract the nerves this way, and then we remove the disc herniation that is over there. For far lateral disc herniations, which they are more laterally located, we usually follow a different approach, the far lateral approach, which is this, let's say, red area here. What is important again is to preserve this bone. So if we use a laminotomy approach, we cannot, which is the blue area, we cannot really reach lateral here because we cannot remove this bone here. So that's why we either go this way or we go that way because we need to preserve this bone here. Now, in addition to the disc herniation, another cause of nerve compression is spinal stenosis. Usually, we reserve that term for when we have overgrowth of the bone or the ligaments. And there are usually three zones that we use to describe the spinal stenosis. It might be a central zone here where we have compression of the thecal sac. We have this lateral recess, which is this area here. And then we have the foraminal zone, which is this area here. So we can have stenosis in any of these three areas and pressure on the nerves. For a lumbar stenosis, the treatment again is pharmacological, physical therapy. Then we can try epidural injections with the interventional spine specialist. It is very important to make sure that we have the patient under an optimal systemic health condition, that if there's diabetes is well controlled. Because remember, diabetes can also cause peripheral neuropathy. So if there is a degree of nerve compression and there's uncontrolled diabetes, then the damage that happens to the nerve is much worse compared with a case where there is no diabetes or there is no uncontrolled diabetes. We can try gabapentin, which can be effective, and it's a very safe pain medication, as safe as a pain medication can be. And in cases of refractory symptoms, we can consider surgery. So when the patient has symptoms that correlate with the imaging, and the symptoms might be radiculopathy that we have already described, or it might be neurogenic claudication. Let me describe this term. So this is pain in the legs that comes with walking. So sometimes we confuse, or there might be vascular claudication from arterial stenosis. One way to differentiate between neurogenic claudication and vascular claudication is that the patient with neurogenic claudication, they say that when they go in the grocery store and they use a shopping cart, and because they can lean over, this forward flexion of the spine opens up the space, creates more space for the nerves. So they usually say that when they use the shopping cart, they can walk for miles, but when they don't have the shopping cart, they need to keep their backs a little bit more straight, then that's when they get the pain and they cannot walk long distances that way. Again, we need to try non-operative treatment first. They say here 6 weeks. Usually it's more than that. It's much longer than that. But again, if the severity of the symptoms causes forced bed rest, if there's any weakness, or if there's any progressive neurological deficit, then we might skip the non-operative treatment and do surgery. When we do surgery, usually we do a laminectomy or laminotomy, and we try to give more space for the nerves. But it is important when we decide to do a decompression surgery to rule out that there's any instability, because if there is already a degree of instability and we go in and remove more bone, we remove ligaments of the spine, then we might make the instability much worse. So it is important for us surgeons to rule out the presence of instability before we offer a decompression surgery. And now we go to when we offer a fusion surgery where we put screws inside, and we'll see some examples. So we do that when there is instability, when there is abnormal movement of the bones, when there is spondylolisthesis, we'll see what that is. When we believe that we need to remove too much bone, that will create iatrogenic instability. And there are some other indications like recurrent stenosis. We have done a decompression surgery. The patient did well for a period of time and then came back with recurrent stenosis. It means that there is too much wear and tear happening at that specific area of the spine. So we need to fuse to, let's say, lock the bones together, take away the movement, because that seems that it keeps on happening. Spondylolisthesis is the translation of one vertebra in relation to the other. Usually is anterior, and we call that anterolisthesis. When that bone slips posteriorly, we call that retrolisthesis. Is less common, and usually it doesn't cause any significant symptoms. And we have here different grades of spondylolisthesis. So you see here the slip. Look where this corner is in relation to that corner. And you see here that there is more slip here, more slip here. So we have this classification to help us quantify the degree of spondylolisthesis. And we usually need standing x-rays because the MRIs and the CAT scans are done with the patient supine. So we might miss the spondylolisthesis or might miss the instability. And a common operation when we do a fusion is the T-lift, where in order to gain access into the interbody space and achieve a fusion between the vertebrae, we need to remove this part of the bone, the facet joint, to gain access and do the fusion. And you see that we usually always supplement that with screws that provide the initial stability while the bones are fusing together. Another option is the anterior lumbar interbody fusion, where you see here that the patient had screws placed from the back, but also has these screws that they were placed from the front. So that requires an anterior abdominal approach, and we usually use vascular surgeons to get us to the spine because they need to mobilize the big vessels to get access to the spine. There are some advantages, disadvantages with each approach. That's a little bit more technical. And in many cases, you can use either approach, and you can have that discussion with the patient and let the patient decide what set of advantages, disadvantages resonates more with them. Now, I'll show you a case where we did a decompression only. So this is a patient with stenosis here and there, and we have standing x-rays that they do not show any instability. And we did the laminectomy. You see here that the spinous processes the spinous processes, they are missing here. And what we cannot see on that x-ray is that also the lamina is missing because we removed it to decompress the nerves. But in this case here, the patient had low back pain, radiculopathy, but on the standing x-rays had a degree of spondylolisthesis. So that's why in this case, we had to do a fusion. You see the screws here and the rods that were placed to lock the bones together. The usual postoperative instructions that we give to our patients is to avoid BLT, avoid bending, lifting, or twisting. So we want them to avoid loading their spine while that area is healing. For decompression cases, I usually tell them like for a month to avoid BLT. For fusion cases, usually it's longer, like 6 weeks. And the complications of any spine surgery, there are some rare complications, but we need to disclose these to the patient because they're very, very serious, like injury to the nerves, to the blood vessels. For anterior approaches, there might be sexual dysfunction for men. And then there are the risks of general anesthesia, like an allergic reaction. Then there are some rare complications like dural tear, infection, malpositioning of the screws in the case of fusion. And then we have some more common complications. So for the case of disc herniations, we have the risk of recurrent disc herniation that usually is anywhere from 5 to 10%. When we do a fusion, the bones might not heal, and then we have a pseudoarthrosis. And another common problem that we have with fusion operation is that we do a fusion operation, everything. Let's go back to this example. So we might do a surgery on this patient and everything to be perfectly fine with this area, but a few years later, he might come back with a problem right above or right below the area that we fused. So this is the adjacent segment degenerative disease. Now let's go to some cervical spine examples. I'll start with a case. This is a young lady that presented with neck pain and right arm pain. And you can see on this sagittal view, the front of the neck, the back of the neck, the bones of the neck. And you see here, there's a big disc herniation that's compressing the spinal cord. And on the axial view, remember, this is the right side, this is the left side. The disc herniation is worse on the right side. So that's why she had right arm pain. She also had the weakness of the triceps. Her gait was also impaired, and that has to do with the spinal cord compression, not the nerve compression. So what we did for this patient, we did an anterior cervical discectomy and fusion, the ACDF, where we removed the disc herniation. You see here the disc herniation is gone. Look here, the post-op, and look here, the pre-op. And because we removed the disc, then we need to put a bone graft in its place, which is this area here, and then we lock the bones together with screws and plates. Now, for the degenerative cervical spine disease, we have axial pain, radiculopathy, and myelopathy. We might have any combination of these three symptoms. Myelopathy, in some cases, might present in isolation with just balance issues, hand dexterity issues, but many times it's associated with neck pain. So we need to ask about the symptoms when a patient complains about neck pain. The clinical evaluation, again, is red flags from the history. We need to ask for myelopathy symptoms, and we do the neurological exam. And sometimes people get confused about the dermatomal distribution and why, C6 goes to the thumb, why C7 is more like the middle finger, why C8 is the little finger. And that has to do with the embryological development of the human body, where the limbs grow, let's say, lateral-wise. So that's why the thumb will be C6, the middle finger C7, and the little finger will be C8. Now, for C5, we check usually the deltoid muscle. We check the abduction of the shoulder. C6, we usually check the biceps. C7, the triceps. C8, we check usually the finger flexors. And for T1, we check the abduction of the fingers. So this is the standard neurological examination that we do to confirm that there is no significant motor weakness. Now, for myelopathy, very common symptoms are balance issues and hand dexterity issues. Usually the patients say that their balance is off, they might be falling. And they also say that they have difficulty in opening jars, buttoning their shirts, or they might be dropping things. There's a questionnaire that asks for these specific questions, if they're dropping things or feel their hands clumsy, if they feel that they're unsteady, if they have any weakness or numbness. And if the answer is yes to 3 or more, then there is a high suspicion that they might have myelopathy. This is the most commonly used myelopathy clinical scale. That's more for the specialist to ask these questions and quantify the degree of myelopathy. And the differential diagnosis for either cervical radiculopathy or myelopathy is quite extensive, and that's usually is done by the specialist. And the imaging workup, we usually get X-rays with the inclusion of flexion extension views, because the flexion extension views can reveal if there is any dynamic instability. And we also get an MRI. Now, in some cases where there is a contraindication for an MRI, then we might get a CT myelography, or if there is a lot of metal hardware and the MRI, there's too much magnetic artifact of the MRI, then we also might get a CT myelogram. And the options are, again, we start with conservative treatment with NSAIDs, physical therapy, and we can also try epidural injections. But for the cervical axial pain, if we see that there is any deformity or instability, or if there is neck pain coming from the compression of the upper cervical nerve roots, then we might consider doing surgery in the presence of isolated cervical axial pain. And In terms of the fusion, if there is deformity or instability, we usually do a fusion also for cervical axial pain. Now, for radiculopathy, we try again NSAIDs, steroids. We might try drug dose back, physical therapy, epidural injections. But if the patient has a progressive neurological deficit or the pain persists after several weeks of non-operative treatment and the pain is severe enough, then we might consider doing surgery. Now, for cervical myelopathy, the first line treatment is surgery. Cervical myelopathy is usually a progressive condition, and if the patient already has symptoms, then there is no point in doing non-operative treatment because this condition will continue to deteriorate. And but if this, the only cases that will consider non-operative treatment if the patient has very, very mild symptoms, if there are significant comorbidities, or the patient has an advanced age and probably the life expectancy is not really that long to justify putting them through surgery. Now, in terms of the options for cervical spine surgery, we can go from the front of the neck, we can go from the back of the neck, or we can do like a combined operation. And this is a comprehensive list of surgeries, but let's see here. When we're doing a laminectomy, the cervical spine, we usually remove the bone from here to there. And when we're doing the foraminotomy, which is a more focal decompression of the nerve root, we usually remove the bone within the green dots. So let's go back to this example that we have a single level cervical disc herniation that is symptomatic. So the main two options that we have for a case like that is to do the ACDF, the anterior cervical discectomy and fusion that we did for that patient, or to do an arthroplasty when we remove the disc and we put an artificial disc. For two or more levels, we can do like an ACDF, like a two-level ACDF or two-level arthroplasty. For multiple levels, we can do a corpectomy where we remove the vertebral body and we put a cage like that here, or we can do multi-level ACDFs. The criteria, it gets very technical and very complicated, and I don't think that it is for, this criteria, I don't think is for today's presentation. It actually can be a very hot and debated and controversial topic in our fields. Okay, so for the arthroplasty, we see here that this patient had a two-level disc herniation. There was no instability on the x-rays, and the alignment of the spine was very good, so we did a two-level arthroplasty. So there are many different types of artificial discs. This is just one of them. And in reality, it's very, very difficult to replicate the very complex movement of the spine and the biomechanics of the spine. And although we have many different types of artificial discs, personally, I'm not convinced that any one of them really replicates all the characteristics of a normal disc, normal human disc. And there are also some concerns with arthroplasty, what will happen like 20, 30 years down the road, because this is a more modern technique, that has been around for 20 years. And for some of the discs that we currently use, they have been like in the human bodies for a shorter period of time. So we don't know how they will behave 20, 30 years later. Now, for the posterior approach, so you see here, this patient had a C3, C4 stenosis and some stenosis in the lower levels, but the mandible is right there. So accessing that area will be very difficult because the mandible is in our way. So we might need to do the operation from the back of the neck. And you can see here that after the operation, the spinal cord is well decompressed because now we can see CSF behind and in front of the spinal cord, where before you could see that the spinal cord was being compressed over here. So this patient underwent the laminectomy. And because we removed the lamina, we also had to put screws inside to lock the bones in place and prevent iatrogenic instability. There's some cases that we can go either anteriorly or posteriorly, and there's some cases that one is clearly advantageous over the other. I think this is a case that a posterior approach is really better. In a case like that, where the compression of the spinal cord is mainly coming from the front, an anterior approach is better because you access directly the pathology and you attack the pathology very, very directly. Remember, if you go from the back, you have the spinal cord in your way, so you won't be able to do anything on this pathology. if you approach that from a posterior approach. Now, for the posterior approach, we have two options. One is to totally remove the lamina, as we have done in this case, and you see the lamina is missing. But again, because we remove the lamina, we create iatrogenic instability. We need to put rods and screws inside to stabilize the spine. Another option is the laminoplasty, where we cut halfway through the bone here to make it more, to be able to bend it. And then we bend it up and we put a plate here to keep it in this way. So that way we give much more space for the spinal cord that is in this location here. And because we preserve all the normal bones, there is no need for a fusion. So this is an example where the patient underwent laminoplasty. You can see here the mini plates and mini screws. And this is a case where the patient underwent laminectomy and fusion. This is a case again of laminoplasty. You see there is multi-level stenosis, so a posterior approach is advantageous, and that patient did not have any contraindications for laminoplasty. For example, instability on the X-rays. And you can see here the postoperative X-rays where we can see the mini plates and the mini screws of the laminoplasty. But in this case that the patient had significant kyphosis, a laminoplasty would not have been a good option. So we did a laminectomy and fusion, where you can see the screws and the rods that were placed to keep everything together. So this is what I had from my standpoint, and I'm open to any questions